Welcome to Care Chats. Join palliative care experts sharing stories, information, and strategies. We're passionate. Join us, and let's get comfortable with palliative care.
Welcome to another episode of Care Chats. I'm Danica, and I'm joined by Brooklyn and Jen. We are a group of palliative care nurses who are passionate about providing palliative care and educating healthcare providers to do the same. The purpose of this podcast is to provide information for all healthcare providers on how to improve their palliative care delivery. This is the second episode, so if you haven't listened to our first episode where we introduced palliative care, we invite you to start there. Welcome back, ladies.
Hello.
Hi.
Today, we're going to be chatting about difficult conversations. So the information we'll be sharing today is largely from the Conversations Matter guidebook, as well as the Serious Illness Conversation Guide. Both of these tools are available on the My Health Alberta website. And as always, we are discussing these topics from our lens and our experiences as palliative care nurses. And as a reminder, we've all been trained on a tertiary palliative care unit, so we come from similar backgrounds and training. We've taken steps to change personal information to protect our patients' identities, and you may find our resources and references in the description of this episode. Difficult conversations are happening every day on every single unit, and so many people are uncomfortable with this skill. Brooklyn, why are these conversations so hard?
That is a good question. Sometimes these conversations are hard because they can be anxiety-inducing for both the patient and the clinician themselves. Other intense emotions can also arise during the conversation, and we may feel uncomfortable dealing with the emotions of others or even our own emotions around some of these conversations. So instead, oftentimes we might avoid, deflect, or even delay the conversation. Another reason these conversations can be hard is sometimes patients have difficulty accepting the gravity of their situation. Denial is one of the several normal coping mechanisms a person may use when faced with a difficult situation. However, this isn't always abnormal or pathological. It can allow a person time to come to terms with their situation. And even if there is apparent denial, patients are often aware of their situation, and it's common for patients to confide in someone else about what a realistic view of their situation is. We want to continue to support them patiently, sensitively, and gently, and allowing opportunities to discuss the illness progression.
Yeah, those are great points and very common reasons why people don't like having difficult conversations. One example that always comes to mind for me is talking about dying and what to expect in the last hours and days of life. Families especially often ask what's happening, what is normal, what are we doing about it as healthcare providers? And this can be a really hard conversation. It's often very emotional. I often even tear up or choke up when I tell them about the signs and symptoms that I'm assessing on the person that we're specifically talking about, the person who's right in front of our eyes. And it becomes personal because we're talking about a real specific person who means a lot to the people in the room. And often it's a person that I've cared for days or maybe even weeks and sometimes even months. And so this really cements the idea that their person is dying, and the conversation can be really heavy. When I point out certain signs like mottling or decreased urinary output, it changes their perception that things are changing. And if there was a last little sliver of hope for survival, regardless of how unrealistic that was, it's no longer there. Over the years as a bedside nurse, I developed a pretty good script of sorts that describes all the signs of death and dying from a head to toe perspective. And I pair that speech up with a pamphlet that I can hand to families. It's made this particular difficult conversation a little bit less hard.
That's a really great point with the having a written resource for the family, and that's available on myhealth.alberta.ca.
Yes, you're totally right, Jen. It's available for anyone for free. There's a few different iterations actually, so you can check it out and see which one works best for your setting and for your role. So this is one example of difficult conversations that I've had a bunch of times, but nurses are often having. Brooklyn, ultimately, whose role is it anyways to have difficult conversations?
That is another really good question because oftentimes it can be unclear on whose job it really is to have these difficult conversations. Is it the doctor? Is it the nurse? Do we involve the palliative consultant team? Other people on our teams? Depending on what the conversation is, will help us determine who's the most appropriate to have these conversations. For example, a nurse wouldn't necessarily be the one to have conversations about prognosis or treatment options. That would lie more with the physician's role. But as Danica mentioned, the nurses could be that clinician to have conversations about what the signs and symptoms to expect as the patient approaches death. I think another important point to note about difficult conversations is that there's often follow-up conversations that can happen. For example, in my own experience, the physician may be the one to have that initial conversation, breaking bad news that maybe the illness has progressed or that there's no more treatment options. And then later on, the patients or the families may ask me questions or confide in me their thoughts and feelings about their situation and what it looks like going forward. So nurses and frontline staff are in a unique position to have some of these conversations because we spend a lot of time with the patients and are the people that are around when the physicians aren't. So no matter what discipline or role you have, every clinician can give space and opportunity for patients and families to talk, ask questions, express their thoughts and feelings about the situation. And sometimes this can be uncomfortable. I know when I was a new nurse, I'd often be anxious having some of these difficult conversations because I felt I had to have an answer. I had to say something. But I have learned sometimes it's not about giving them an answer, but just an opportunity and space to express their thoughts and feelings and provide validation and support in that moment.
I like that a lot, Brooklyn. We can all make space for healing regardless of our role. Expectations around difficult conversations are different depending on what your role is, and even within your own team and what your profession is. But there are definitely some universal skills that we can all use to make them more manageable. Jen, do you have some examples of some that you like?
Oh, I can think of a few. One thing for sure that is universal, no matter what your designation, what your profession, what your role is like you guys said, holding space, validating people's feelings. And also, silence is not always a bad thing. If you don't know what to say, it is completely okay to not say anything at all. Sometimes just being present and having that supportive presence is valuable. But there are some techniques that I kind of picked up that there are resources on that I like. So one of them is the Amen protocol. That's actually from a journal article from 2014. So maybe a little bit outdated, but I think the main points are still valid and still very useful. So Amen stands for A for affirm, to validate their belief. M for meeting the patient and family where they're at. So this is more for families and patients who have really unrealistic expectations. Maybe they're hoping for a miracle. So kind of meet them where they're at. We're both kind of hoping for the same thing. We're on the same team. We have the same goal. E for educate from your perspective. I would hope for that too, except that these are some things that I'm seeing that make me suspect that we're looking at a prognosis of hours to days. So that's when I would usually jump into those signs of death and kind of talk the family through what we're seeing. And then N is no matter what, reassure of your support. So we're in this together I'm at the bedside for the next 8 hours. If you have any questions at all, you give me a call. We'll talk through it. Another resource that I like to use is a serious illness conversation guide. This is probably more geared towards MRPs, so physicians and NPs, in terms of having those big family meetings. But it can be useful. It has some really useful items that we can use as nurses at the bedside as well. So, set up the purpose of the conversation, get consent to talk about things. I always like to get consent to talk about things in front of whoever's visiting at the bedside because you never know what the patient is comfortable divulging to their visitors, even if it's immediate family members. Assess their understanding, what's their knowledge of their illness, how much do they prefer to know. Some people like to know everything, like Brooklyn said last time, and some people, like to defer to certain family members to know more of the medical details. Share the prognosis, share your knowledge of the situation using wish, worry, or hope and worry statements, similar to the Amen protocol. Explore their goals, their concerns, their priorities, how much family they want to be involved, and then provide a summary of the conversation and maybe some recommendations for moving forward, and then reassure them of your support. Always make sure you document, so encourage the tracking record for goals of care conversations, and we'll get a little bit more into that in a second. And communicate with whichever care providers also need to know the result of that conversation. So, like I said, the serious illness conversation guide is maybe geared towards kind of the MRPs having those big family meetings for those big decisions to be made. But something that I've noticed in terms of all the different techniques in having these tough conversations are a top 3 set of questions. So it's really exploring the patient's knowledge. What do you know? Maybe don't word it like that. Exploring what their worries are. So, what are your concerns? What are you worried about? And then also exploring what their hopes are. So, for example, I've been asked by staff how they should respond to someone who asks them, "Am I dying?" Kind of an awkward question to ask when you're trying to take someone's blood pressure, right? But there can be a really simple response, which is just open-ended questions. What makes you ask me that? What's going on that made that come to mind? Another common question I've been asked is how to respond when someone asks you about their prognosis. So, how long do I have to live? Bedside nurses might feel less equipped to handle these conversations because they don't often know all the medical details, and we don't have time to go through the chart for all the nitty-gritty details of the patient's condition. And it is also just as easy to say, an excellent question for your doctor. Let me pass that message on. But let me also tell you that there's a lot of physicians and MRPs who have the same awkward feeling about providing a prognosis. So, using those open-ended questions can really be useful in facilitating that discussion, and that'll allow you to support the patient with what they think their prognosis is. So, okay, how long do I have to live? Oh, well, what have you been told about your disease? What have you been told about your prognosis? Is there anything specifically you're worried about when you hear about this prognosis? Let's say they've been told they have 6 weeks to live. How do you feel about that? Kind of exploring more about what they want and then talking about what their hopes are, right? Okay, maybe they're hoping for a miracle, but maybe some people will also say, I'm not afraid of dying, but I'm really afraid of what I'm leaving behind for my family. And so that sometimes can be a really good jumping off point in talking about personal directives or power of attorney, kind of setting up your wishes. And if they don't already have a personal directive, we're always encouraging people to make sure they have one while they still have the ability to appoint a decision maker. So these open-ended questions will really help guide you in exploring further with the patient. And you don't always have to have that magical answer, right? You just sometimes have to ask the right question.
Also, some of these conversations don't necessarily have to have an end point or a conclusion. Sometimes people just need to talk. And if you're the person who's around, if you're the person who's there doing their blood pressure every morning, or you're doing a bed bath, and they feel like they can trust you and they can open up with you and they know you'll be in their room for 10 minutes, maybe they just need to get something off their chest. So I think it's also an important reminder to just have that mindset that it might not lead to anything, and that's okay too.
Yeah, absolutely. That's something I think that we'll get into too when it comes to documenting those conversations, because it is really important, even if you haven't reached a point in that discussion where a decision is being made that impacts the patient's healthcare, it's still important to track that conversation so that other healthcare providers can refer to it later.
So I really like the idea of these 3 questions, Jen, and the answers to those 3 questions can also help other team members focus in on their conversations that are more specific to their roles and their professions. If you can glean a little more information about the person's understanding, about their fears, and about their hopes, and then pass that on to the rest of the care team, they can use whatever expertise they have to address different patient needs. So we had a patient that didn't want to stop their cancer treatment one time, even though they only had weeks to short months to live. Everyone on the care team thought that they didn't understand that they were dying, and there was discomfort on the team, and people were really uncomfortable about this idea of patients continuing on with their treatment. But through asking the right questions and taking time for difficult conversations, I found out that the patient actually totally understood that their condition was terminal, but they were terrified to die in pain. And that's why they didn't want to stop the treatment. So the information actually totally changed the focus of the conversation and changed the focus of the care as well. And we never would have found that out if we hadn't taken a bit of time to ask the right questions and to put ourselves in an uncomfortable discussion.
That's a great example, Danica. And something else that comes to mind too that we have experienced with our palliative patients is sometimes the patient will express a wish to die. And if it doesn't get explored, it can very easily be interpreted as a request for medical assistance in dying, which is very valid for the patient to request if that's what they actually wish. But it's also really important to explore what they mean when they say, I want to die. Because some people, they just say, I'm done with life, but I'm ready. Like I'm ready for the natural process to take effect, not necessarily that they're ready to, you know, actively end their life with medication. So talking about tracking records, I know I'm harping all day about tracking records and personal directives because it is important. And we as healthcare providers sometimes are the worst offenders when it comes to having a personal directive in place. Danica, Brooklyn, I challenge you both. Do either of you have a personal directive?
I do.
Great.
I do not.
And no
I'd like
matter
to think
what,
I'm too young, but we know that's not truth.
yeah, I know. We were just talking last time about how the median age can be quite young, maybe not quite as young as yourself, Brooklyn, but we are the worst offenders. Even if we are young, it's still important to have these things in place because otherwise there is kind of a legal cascade of decision makers that the healthcare providers would go to. So if they're, if your mother or father or your spouse, you don't want them to be the primary decision makers. If you can't, then it's really, really important to make sure you have a personal directive in place and that you've spoken to all the relevant parties so that everybody's aware. But yeah, so for more information on personal directives, goals of care, tracking records, go to Advanced Care Planning, Conversations Matters on the Alberta Health Services website. Is that right?
Yes, that's right. And you can find some more information about personal directives on the Government of Alberta website.
Thank you. So we should always be encouraging the MRP to complete the tracking record whenever they're having a significant goal of care conversations, even if, like we said, even if a decision isn't being made at that time, it's still important to document and to be able to easily access that conversation, especially if the patient has expressed wishes that they don't express on a daily basis, for example. So it's just easier for future healthcare providers on the next encounter to refer back to. For example, if someone presents to emergency, then, the emergency team doesn't have to start from scratch with those conversations. They can kind of look back and see what's already been discussed. And this is especially relevant for those with maybe a more prolonged illness journey, like heart failure or COPD, for example. It'll just be really helpful in guiding all those future discussions. The tracking record is a document in Connect Care. So when you make your note, instead of, let's say, your handover nursing note, you would type in tracking record, and that would kind of show up in a different area of the notes. There's also a paper version for places and facilities that don't use Connect Care, right? But to know that any healthcare provider can complete an entry in the tracking record. It's not just for physicians, it's not just for nurse practitioners. It can be bedside nurses, it can be healthcare aides, it can apparently also be housekeeping. I'm not sure how often housekeeping would have access to that documentation or be having those conversations, but very worthwhile if there is a very relevant conversation being had about the patient's wishes. At the bedside, as nursing staff, it's not necessarily, like Brooklyn said, our job to be initiating these goals of care discussions, but it's certainly within our scope to explore with the patients and their families what their fears and hopes are. Like if a bedside nurse has a conversation with the patient that they feel will significantly impact goals of care discussions, like let's say the patient has told you 8 times during your shift that they are just ready to die. Why are you poking and prodding me? I mean, hopefully it doesn't take them 8 times before you contact the MRP to maybe have things changed, but very important to note, right? So that would be something that's significant that goes into the tracking record. It's very helpful to document so that the MRP, when they're having those major goals of care conversations, or perhaps a palliative consultant, they can refer back to those conversations and kind of get the conversation going from there. Also, keep in mind confidentiality and expectations from your patient. So, for example, if they ask you not to tell anyone, or there's certain people that they don't want involved in decision making.
Those are all really important points. And I have a story about when a tracking record was so useful. So we had a patient one time who was an elderly person and they had many adult sons. The agent in particular was upset about their parents' illness journey and wanted a lot of aggressive care to be done. In particular, he wanted IV antibiotics over and over again, even though the IV kept going interstitial and the patient's arms were just like giant water balloons, like just the thinnest skin, and you could almost see the interstitial fluid underneath her skin. So it was impossible to maintain IV access. The nursing staff and team in general were getting frustrated, understandably, and they just didn't understand why this was happening and why we were caring for this person in this particular way. They felt that they were being asked to cause harm, which I know is a common feeling. Sometimes people, if you don't understand where family is coming from, it can feel like we're hurting them on purpose. One of the physicians on the team sat down with the agent and spent time asking that person what was behind his decisions. So the son shared the story of his other parent dying in hospital and how the patient had reacted to that, and how the patient had felt that not enough had been done for their spouse at that moment. And so he was trying to respect his parents' wish now, and that's what he was using to guide his decision making now to try to do what he thought was best. So the physician wrote, a short version of this in the tracking record and shared it with the team, and it was so helpful. The rest of the team was able to get the background, and the son didn't necessarily change what they want or change the goals of care, but it was helpful for the rest of the team to have a glimpse in that person's experience and to make a little bit of space for empathy and to shed new meaning in his decisions. It didn't change the outcome, unfortunately, but it did make everyone a little bit more aware and definitely more understanding. So in this case, communication through the tracking record helped the team process what was happening and move forward. But what are some of the steps in making sure communication is interpreted correctly by patients and families?
The first step is to know your patients and families. This is something bedside nursing staff excel at. You spend 8 to 12 hours with your patients. You are witness to their most intimate moments, and they often tell you things in the moment that they will never think to tell the MRPs. What's important to them? What were they like before their illness? Who are they as human beings? Once you have an understanding of where the patient and family are coming from, like in Danica's story, communicated through the tracking record, it's easier to find a common ground and explore more of their wishes and goals, as well as frame those goals in the context of their condition. So, okay, you may not ever be able to run a marathon again, but what can we work on that will actually improve your quality of life based on what we're working with? But also, it's important to remember having these tough conversations is not always about changing the patient's and family's mind to match your goals. So I know, like, even with your example, Danica, that a lot of the staff are really upset about the interventions that were being provided to this one patient. We as staff often apply our own wishes onto the patients, and we forget that sometimes, like, my idea of a good death is not necessarily the same as my patient's. So sometimes people will just die with GPN and IV antibiotics, and that's just how the journey goes. Or, people will die without life prolongation. And if a staff member disagrees with that, like, that's also just how it goes because it's based on what is important to the patient. It's not about my goals matching your goals, it's about being part of the same team to reach attainable goals. Our work as nurses, especially at the bedside, is to ensure the patient is as comfortable and dignified as possible, despite the way we may perceive inappropriate interventions. So Danica's story about the patient with the IV is a very good example of this. While the MRP is having all these big goals of care discussions, it's still my job to make sure that the patient is comfortable, that we're not causing harm. And if our perception is that we're causing harm, it's also really important to document what it is that we're seeing that we're interpreting as harm.
Well, I think that's a great place to end this conversation. Everyone has different ideas of what a good death is, about what is comfort, about what the role of medicine and pharmaceuticals is. And unless we communicate clearly, even when it's hard, we'll rarely get on the same page. So you can find all the resources and references in the description of this episode. Please take a few minutes to fill out our feedback form and let us know if you have any questions, if you'd like us to address in future episodes. Until next time, bye.